Good afternoon, everyone. So my name is Tinglong, and I now have the honor and pleasure to introduce Dr. Brian Lin from Stanford University. So Dr. Lin is a primary care physician, entrepreneur, educator, and researcher whose work keeps medicine centered on people while advancing digital health, medical technology, and innovation care models. He co-founded and co-directs Stanford's Center for Aging Health Research and Education, also known as CARE, and leads Stanford's Medical Humanities and Arts program. Previously, he established the consultative medicine clinic, evaluated complex medical cases. He created and co-teach Med 216 generative AI and medicine at Stanford, and is working on several generative AI-related research projects. So Dr. Lin earned a Bachelor of Science and the Master of Engineering degrees from MIT in electrical engineering and computer science, and also MD from Tufts University School of Medicine. He completed the internal medicine residency at Tufts Medical Center, followed by Stanford Fellowship in Biodesign and Cardiovascular Medicine. He's board certified in internal medicine. So without further ado, so Risa and I are going to ask Dr. Lin and Dr. Nadkarni several rounds of questions. And the first round of question I'm happy to kick off is that, so today is September 12th, 2025. Around the same time last year in New England Journal of Medicine AI, Native AI, that's a journal a lot of us have been following. Girish is a Dr. Nadkarni here, and his co-authors published an article called "If Machines Exceed Us, Healthcare and an Inflection Point." So as this publication approaches the first anniversary, Girish, would you mind just briefly explaining your point from that article? And do you see some of the visions from the article become more real or less?
So thank you, first of all, to Dr. Dye, Dr. Wolf, Dr. Polsky. Thank you for this invitation. It's a privilege and an honor. Um, so our article asked a simple question, right? And more of a thought experiment. What happens if clinical AI systems reach and in some case exceed human performance on clinical tasks across in a variety of domains, diagnosis, treatment planning, empathy, uh, uh, prediction, etc., etc. Now, I want to acknowledge that ASI or artificial superintelligence is speculative at best and a distraction at worst. But that being said, I think um, the core of, and I'm a practicing physician like some of you are, the core of medicine at its center has to be human centered, right? The values, the morality around it has to be human centered. So if there are models that like exceed us on cognitive tasks, they may or may not have the same value systems as humans broadly and physicians particularly in specific have, right? Now, there's obviously opportunities here, right? There's earlier, more accurate diagnosis, better treatment selection, AI guided surgery, other procedures. But there's also the danger that these systems could prioritize values in significant ways that differ from ethical and human values, right? And this is compounded by the fact that in most cases, the reasoning that goes behind these decisions is kind of opaque and not completely interpretable. Now, the point that article try to make is we haven't hard coded medicine in terms of values, ethics, governance to make it more human centered, and this gives us and that was fine because medicine was run by humans for humans, right? But at some point of time, if machines do exceed us, have we hard coded these values into our systems so that care and medical care at its fundamental remains human centered? And I would argue no. So it also has a clarion call for planning now and multidisciplinary groups coming together, clinicians, policymakers, technologists, patients, right, to make sure that as capabilities scale, care and medicine remains unequivocally human centered. And ASI might happen in the next 5 years, next 20 years, next 50 years, may never happen at all because the definitions keep moving. But at the same time, if you hard code these rules, yeah, and if you sort of build a system for humans and make it human centered, then I would argue that whatever comes in terms of ASI, AGI, etc., we will still make the care human centered. And I'm arguing that in a subsequent thought piece, I also argued that current structures are not meant to do that, right? So there's an example I use of the Maginot Line. Do you know what the Maginot Line is? So during World War II, uh, 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 the allies like built fixed fortifications. So to prevent tanks from getting across the fortifications, the tanks drove around them. So it gives you the illusion of security while at the same time not having any really security because things can go around them, right? And so if we built sort of fixed fortifications or fixed governance structures or this, then AI agents or ASI will simply drive around them because their ethical values don't align to this. And that's why we need to shift um, from a more uh, fixed governance structure to a more adaptive, more evidence-based, more observable governance structure with human oversight to ensure that, again, medicine remains patient and human center and patients benefit in real time. So I think, while ASI, AGI, or whatever we want to call it, might be speculative, it sort of behooves our larger community who have been entrusted with this responsibility of caring for patients to prepare as if it was already here, because in that way, you're sort of preparing potentially for any eventuality that might come.
Thank you.
I couldn't, I mean, I couldn't agree more with what Girish said. I think, consciously embedding human values and human-centered care in whatever new technology is really important. I think that is actually we need to generalize that through everything because I do have a little bit of a nuanced view in that I would argue that care has become less human-centered over the years because of the corporatization of healthcare. So, and this is a great example of, it's not necessarily technology-based, but it's, business and institutionally based, right? We're now we've gone from the ideal of the, small town doctor who knows everybody and everybody knows the small town doctor to the point where you've got people who think of it's a salaried job and you switch and you switch and a lot of patients complain they've got a new doctor seemingly every couple of years that they've got to really get comfortable with. I just wanted to share that the patients also the mentality is changing as well and their acceptance. In Silicon Valley, of course, we've got a very AI forward community. I was invited to be in a panel here locally at Stanford. We had a panel on medical education, and I asked, and the question was, what's left for doctors? Like if AI can do all of these things, what's a doctor good at? And so I just out of curiosity, because I'd done this in my classes, I asked everybody, I said, hey, how many of you would be comfortable having an AI doctor? And actually, of course, because of the audience, people attending an AI, symposium, they're going to be into AI. So many people, most, like I would say 70, 80% of people raise their hand, quite a lot. And then I said, okay, how many people would be comfortable having an AI doctor if you were diagnosed with stage 4 cancer? So still people raising their hand, but fewer people. And then I said, hey, how many people would be comfortable having an AI doctor if you were at the end of life? And surprisingly, there were still a few people with their hands up, but much fewer. So I think, embedded in, everything Girish said, is also the kind of awareness of what we are good at, like what we as humans. I mean, of course, you can always argue with, ASI that there's some facsimile, right? There's a facsimile of empathy. 2 years ago, there was the famous study which showed that, AI is was rated as more empathetic, right, than doctors. And it was looking at Reddit. Reddit asked the doctor questions, and they had blinded physicians judge the appropriateness of the response, but also how empathetic and longer responses and the phrasing that AI LLMs use tends to be perceived as more empathetic. But is that true empathy? Is that facsimile of empathy? Is that good enough? And I think still it's not good enough for most people. That view may change. So that's one thing we don't know how society will change with, as we have more advances in AI. But I totally agree with Girish that, embedding and taking a conscious effort to embed that into our systems. But I mean, I think unfortunately, despite his work and publications and other people, I don't think it's being done. From my viewpoint in Silicon Valley, every day I have students emailing me their latest business plan about what they want to do, and you got VCs contacting me and asking me what I think of certain startup ideas, and that is, I have to say, probably the last thing on their mind, right? And
Right.
it's unfortunate. So this is, brings into a kind of question about what's the role
So,
of governance and policymaker, which is also challenging. Sorry, yeah, go ahead.
Dr. Lin, let me just step back a little bit. Can you just, you know, very quickly define ASI just from purely technical standpoint, from your being extremely neutral position of being in the Bay Area, the probability for ASI to happen in the next, let's say 10 years or 20 years.
Yeah. Yeah, I can't read the tea leaves, so I'm not going to put a number to that. I think, you'll get ranges from 2 years to, 10 years to never, right? I mean, that's really the span of, and that's a reasonable span, I would say. So my response is, yeah, maybe, something brand new comes up. You know, when when the paper about, it's all about attention or whatever that was called, right? People didn't expect that, and then the LLM. So there's lots of things we can't predict. So one thing I've learned from patient care first, but other things is it's really hard to predict the future when patients ask me, I'm like, geez, I think if it's really going to happen soon, most people can predict the future, but if it's happening a year plus from now, we're pretty bad at predicting the future. I think one definition I would use, and it's, again, mainly from a practical perspective, is, can there's two parts, right? There's the human in the loop and not human in the loop, right? So, if we're ever at the point where we are comfortable and we have, good evidence that, AI is outperforming us without the human in the loop, you could consider that a type of artificial superintelligence. My wife works at Google and she was laughing at me and she's like, you guys are, totally behind and don't know what you're talking about. So, every industry is different as well, right? I just think of that from a perspective of a practicing primary care doctor. I do have to say, though, interesting, just again, back to the systemic changes, I do see, I think about what AI would take care of first, like from a primary care perspective. I practicing at Stanford for 20 years. When I first got here, it was a typical practice. You'd see like a simple case like a urinary tract infection or sore throat, and then you'd have your complicated patient. Then you'd have a simple case, then you'd have a complicated patient. Just because of our systemic changes, now I'm seeing complicated patient, complicated patient, complicated patient. All of the kind of quote unquote straightforward medical cases are taken care of by the system, either through urgent care or through, my health messaging or something like that. So I can see with AI that's probably going to happen, right? That's going to be more so of taking care of the easy stuff, the stuff we don't want to do, right? But then, of course, that makes our life more complicated on the other side, right? Then we are, truly, they use the term practicing to the level of your license. We are then truly practicing to the level of license. But then, of course, does that mean we're all burnt out because, we're taking the toughest of the tough and challenging cases because AI is really good at getting the average thing, right? It's trained on the average thing, right? The most likely thing. But unusual cases, less common cases are exist, and humans can be good at that, for expert clinicians. So it's interesting. Just I always think about that parallel between change in general, like systemic change and AI change, right? It's still just, and again, an impact on AI on the system and how we practice medicine as a whole. I
Thank
don't
you
know
for
if
that.
that,
You know, it's
I don't know if that answers your question, Tinglong.
It does. It does. Thank you.
it's interesting because you say that it's a good point that obviously as maybe AI in the future might take care of simple cases, but then the more complex, and obviously we want to push for things that can be done by a machine to be done by that so that, we can take care of the more complex. So it's just the perspective of, okay, well, now I don't have to take care of that, but it could be tougher. But then if we're expected at the end to be able to manage the tough, you also have to have the basic foundation of the sort of simple. So then I hope there won't be a gap, or I mean, I love your thoughts on whether there'll be a gap in what people know if we're also relying on AI as for some of the sort of basic things. And, this will get to our questions later about medical education, but maybe I'll just pose this one question about it. How do we think we're going to close those gaps later?
Maybe I'll jump in for a minute, right? So think a lot about this. So there's two issues that happen with clinicians when there's AI sort of embedded in a lot of workflows, right? There's de-skilling and there's mis-skilling. Descaling basically means that if you use AI too much, you lose your clinical skills. And that's been shown elegantly in a new annals paper where endoscopists who use AI augmentation, actually after they did this, they found less polyps. And even when they found polyps with AI, it was like, they were like adenomas that didn't matter, right? But the other important thing is mis-skilling, right? And also known as automation bias is basically when you get information from the AI and you stop thinking critically and you just trust the AI too much, then you're over-indexing on the accuracy of the AI. And as a result of that, you are going to make mistakes, right? And then this is kind of critically important because if also viewed through another lens of who's responsible and who's liable, ultimately the liability standard right now, and that might change, is the standard of care, right? Whether you reach that with or without AI, right? Because if so it introduces a whole new axis of liability, because if you listen to the AI and didn't reach the standard of care, you're equally as liable as if the AI provided the right recommendation and you didn't listen to it, right? So in that, if clinicians, which I think for the foreseeable future are the end effectors and the person responsible for the charge of the patient, I think there are two skills that need to be taught, is how to maintain your skills, clinical, procedural, or otherwise, when AI workflows become sort of omnipresent in clinical care. But at the same time, critical thinking in order to both evaluate the recommendation that an AI algorithm or an AI agent is giving to you, but also know when that recommendation is wrong and not listen to it, right? So I think, in my opinion, critical thinking and you know uh, just the art of medicine, and I'm using this term very loosely, but I think clinicians know what I mean if they say when I say it, are going to become more important, not less important, just because of the fact that now there's a way to make things more efficient, but at the same time, you need like a filter to maintain the standard of care before sort of it reaches the patient, right?
Yeah, I think I totally agree. And, I think we just have to look at, coding, right? People, so we look at other industries, right? So what's happening with programmers right now, right? So there is a serious concern that, all these entry-level jobs are being eliminated. And then, how do these people who normally would take the entry-level jobs, how do they learn to become to the next stage? So, in writing, it's also very similar, right? If you don't write it, are we all just editors at that point? Is it a different skill of being an editor versus being a writer, or do you always need both? One of my colleagues has a project where they've developed an LLM based sort of coach to identify, are you critically thinking, as Girish said, about the case? What is involved? How's your knowledge for a particular case? It will kind of rate your critical thinking involvement or your through interaction about discussing a case or your knowledge. And her argument is we're going from a model of a knowledge based kind of profession to more of a critical thinking profession. But I do think you still need that especially with challenging diagnoses, you still need that underlying knowledge to call on. You can't always be kind of looking things up. There's just too many things. I studied engineering before I went to medicine, and we didn't have to memorize anything, right? It was all like derived from first principles. And especially a place like MIT was very kind of purist, right? They're teaching you how to think and not teaching you stuff. But I think in today's, with today's technology, you need both. You need to know some things and have that data in your head, not necessarily at your fingertips. It's funny, for programming, they did a study on looking at, who are the better coders. If you looked at, I can't remember if it was Java coding or Python, looked at people who just learned on their own versus learned plus an AI, or had the AI write it versus. So the people who actually learned on their own really had a better understanding of what they were programming versus somebody who was using the assistant to code it first. And then you're editing and debugging it later. So yeah, I think it's a serious concern about our education. We need to change our model of education, but make sure that they aren't losing those fundamental skills. And in particular, again, harkening back to what Girish said, those human-centered skills, right? So we need to make sure those are really embedded as well. Like history taking. If it's all ambient AI, does that mean we're going to get worse at history taking, right? Because it's going to gather information. It's going to look great, right? It gets put, DAX Copilot, it looks great. It creates this node and it looks like you had this great conversation. But does it mean you really, followed that chain of thought as an experienced clinician does, following these things where you said, hey, that doesn't quite sound right, right? Does that make us a little lazier, like in the endoscopy example, right? Does that make us like, oh, well, it's getting captured and, it's going to tell me what to do, or it's going to suggest what I do, right, as the next step. So yeah, it's really challenging. And, I think people are working in this, which is great.
I think that's a really a perfect segue to the next question, which is for sort of taking a big picture step back, where are we now in terms of real world AI applications in healthcare delivery? And from a technical standpoint, what breakthroughs do we need or are needed to move from today's AI to truly super intelligent AI in healthcare? I don't know.
I can go first if you want. I think in healthcare, there's a lot of excitement, but there's also a big paradox, right? So we have a lot of stuff that we're doing on the research side of things, and that gets written about and put in papers and put on the shelf, and we never translate any of those things. And then on the clinical and operational side, we do a lot of things, like mostly through vendors, but that never gets researched to make sure it's effective, safe, and ethical. And we need to bridge that gap, right? Like, for example, there are you ask any health system chief medical officer, a chief medical information officer, or a CIO, there's probably like 80 algorithms running through EHR vendors, through radiology, through back office, et cetera. And if you ask any of them, how safe or effective they are, no one knows. So there's this massive translational, etc. gap that we need to bridge somehow. So whatever we implement gets adequately researched, and whatever we research gets adequately implemented. The other thing is, like, infrastructure in healthcare systems is not really AI ready, right? I did residency around whatever 12, 13 years back, and we used pagers then. Some people use pagers now, right? The modern EHR systems are really not built for. They're getting better, but they are not really built for AI readiness. The workflows are not really built for AI readiness because they are configured with old non-cognitive technology in mind. And the problem is these workflows are so essential to the functioning of the hospital. You remove one small piece of them and the whole system crumbles, right? So yes, now there's two options in healthcare, right? One is to sort of automate bad workflows, or the second option is to design new workflows from the ground up that can actually take advantage of the newer technological capabilities, not just AI, but a bunch of different things, right? That's one thing. The other issue is data in healthcare is extremely siloed and extremely separated from one another. Like there are several systems of record for different things, right? Radiology is a separate system, echo has a separate system, etc., etc. So as a result of that, building truly multimodal, but also understanding models becomes hard at scale, and that's why it's not like data on the internet which can be collected and used for larger AI models. Then the last thing also is a more regulations one, right? Um, and this is where I don't know the answer because there is no standard set of regulations or guardrails at the federal level, right? So that lead to one code of one thing that you have to follow across the nation. States and cities are going to start making their own regulations, right? And as a result of that, what AI implementation in New York could look very different from AI implementation in Arizona, could look very different from AI implementation in Maryland, right? And that introduces a fresh level of complexity. The last thing is, and I don't mean to sound about it's all dollars and cents. What is the business case, right? What is the economic incentive to adopt this new workflows, right? Either it has to benefit the top line or the bottom line. And if you just put in more and more regulations and that requires more and more compliance and more governance, right? It's going to be this. So until we find like an actual business case, adoption is going to, which ultimately includes either cost savings or reimbursement, right? The adoption is going to lag.
Yeah, I mean, again, totally agree. I think just commenting on the data piece, um, we're basically maxed out, right, with LLMs. They basically utilize all the data we have in terms of, the internet. So I think we need to pay a lot more attention in really gathering high quality data that's unbiased for training, or fine tuning or whatever the case is, our future applications. So I think that's a huge barrier to, advancing AI is just the data and making sure we tend to use data sets of convenience, right? It's like, oh, Mayo has this huge data set of all of this, and they've anonymized it. It's available. Okay, I'm going to use it, and that's great, right? But it's not necessarily a substitute for, a data set that is intentionally curated and balanced and deep. So I think that's one of the challenges. I think just to comment on on the patchwork system, how we're the implementation challenge. I give the analogy of how when you're an intern and you learn all these things intern year, right? About, I mean, again, to put an arbitrary number on it, 50% are things that are medical and 50% are things that are very specific to your hospital, right? If you took an intern, in September, so they all start in July or end of August, end of June, and if you move them to a different hospital, they would have to learn how to, get things done in that new hospital, right? So similarly, rolling out anything new from a technology standpoint, right? It's going to be a different implementation because the workflows are all different. And then, yeah, in terms of the funding, the business case drives everything. Absolutely, just like in research, grants drive research questions. The business case and who's going to make money, how you're going to make money drives everything. One comment is, an area we haven't touched on is, I think there is a lot of promise in AI and drug development, and this, if we ever do have this, ASI, at least in the drug development, I don't know if it's how general it would be, I mean, I think that will potentially make a huge difference in terms of our ability to push forward new treatments, and they don't necessarily have these other barriers that we're talking about. Last comment about the FDA. I have a startup now that I co-founded, and we applied. Was it end of? We got FDA approval end of 2024. Was that 2024? Yes. Sorry, end of 2023, December. And we have an AI component, and they are definitely way lagging on their, implementation and guidance and knowledge from a practical sense. I mean, they do have guideline documents and so forth that are thoughtful, but in terms of their implementation of those regulations, they're really behind. And generally, FDA on the digital side, which is really falls under the device category, not on the drug, they don't have any capacity to provide enforcement. On the drug side, they've got probably 10x the number of people involved in enforcement of FDA regulations. But in the device and digital side, they tend to pick one example and go after them. But it's very difficult given you've probably got 10x the number or more than 10x the number of new software that has some involvement in diagnosis or a treatment of disease that they're never going to see or never going to be aware of. So absolutely, it's very challenging, how to regulate this.
So we talk about a lot of barriers to ASI. Have a data challenge, we have regulatory barriers, we have workflow challenges. Now, I do want to connect back to Girish's earlier point is that we should operate or we should get ready as if ASI is going to happen. So speaking of that, when people think about ASI, the kind of super intelligent models, even more capable than we are, immediate concern would be AI take over, right? I know that sounds silly, but we have some very serious people like, Jeffrey Hinton actually alluded to the possibility that AI might want to protect its own survival, might actually want to dominate humans. Now, his solution is so-called, think about from AI, not adopting AI, but more of AI will be adopting us. And his proposal was to say we should design AI systems such as they have these maternal instincts. Think of AI as a mom, essentially, right? So is that realistic or meaningful approach in healthcare ASI design? Suppose ASI has already been realized. Is that something you are going to project that in healthcare systems?
So the problem with ASI, speculative as it might be, is that the value system that it adheres to is going to be completely it's unknowable what value system it adheres to, right? Like, it might adhere to a value system which is completely alien, literally alien to us, right? And as a result of that, its actual motivations, etc., might be unknown. So yes, it's if you think about ASI as like just a super brain, you have the left side of it, which is non-deterministic or much more. Left side of it, I get confused. One side of it is probabilistic and like creative, and the other side of it is deterministic and logical, right? So if you think about such systems that can be built, like neurosymbolic systems, where you have a fusion of both the creative and non-deterministic parts of it, but also with the logical and hard-coded parts of it. That's where you could think about hard-coding a bunch of rules, right, that need to be adhered to so that you can actually hard-code these rules into the system. And these have been done. I mean, ASIs can be a completely different beast, but if you take some guardrails that have been put in, even current LLM chatbots have guardrails built upon a combination of rules-based logic and reinforcement learning that they can't adhere to, right? So that's one thing. The other thing is, especially in healthcare, you need sort of constant monitoring and red teaming because and auditability, right? like you need to make sure that the system is adhering to the given guardrails at one point of time. B is you need a auditable, trackable log of all of the decisions and uh, actions that are taken by this system. And C, you need immediate rollback plans if it falls beyond those guardrails, right? And you need, because healthcare is all about part of healthcare is all about risk management. So you need to regulate the systems or govern the systems with the idea of what's the worst possible thing that can happen if this completely goes off the rails, right? And accordingly, you need to tightly monitor and regulate that. And this is not just true of healthcare. This is true of all safety critical industries, be it aviation, be it nuclear power, etc., etc. You govern, systems based upon risk of failure as opposed to risk of success, right? So you need to like figure out, and yeah, this is a more conservative approach, but it protects, it hedges against the downside.
Yeah, I think, of course, there's always the dream of, I don't know if you guys are sci-fi fans, the three rules of robotics, right? The Isaac Asimov Foundation, right? So check it out on Apple Plus. They don't pay me anything. The three rules of robotics, like essentially like don't hurt any human, don't hurt any robots, that kind of thing. I forget exactly what they are, but I think it because we have no idea how artificial AGI or ASI will come into being. We may not be able to put a control system in that part, right? It may be antithetical to creating an ASI. Nobody knows, right? We have no idea. So, the easiest thing to do is more to place control systems on what they can do, right? And that's effectively what, we're doing now with LLMs, right? The control systems are, there's some reinforcement learning, but, a lot of them are like, changing the prompt or saying, hey, you can't talk about these things, right? So we're intercepting the input and output. And but that's challenging, right? Always examples, even today, right? People, circumventing one of my colleagues, Jonathan Chen, tried to force LLMs to do something funny. And usually you can do it, right? It's possible because it's such a complex system. So but in terms of that agentic part, right, the part that's actually going to hurt us because it can do something about it, that's probably going to be where we would put, control systems and rails there. But it's hard to do, right? Once you've got that there, I've got two teenage boys. If you've got if you've got a million teenagers trying to circumvent your security settings on the school, they're going to win. They're going to win every time. So I think every parent will agree with that. So I think it's tough, but it's all speculative, but it's fun to talk about.
That's great. Thank you. And I think maybe I'll ask one more question and then we'll go to some of the audience questions because we have a few already. So let's imagine we just fast forward to a future where true ASI is embedded in healthcare. What is one development or one thing that you in the future that excites you the most? And then what's one scenario that maybe concerns you the most? And I know we sort of touched on some of these things, but maybe we'll wrap up with this discussion before we get to the audience questions. So something that excites you the most and one that concerns.
What excites me the most is two things, right? If you think about AI as encoded knowledge, it's an arbitrage or an exchange of knowledge for time, right? And that basically means, in the case of ambient AI, giving back time to the physicians, preventing burnout. But in the case of predictive AI, giving enough time to make an actionable decision, right? So it's an exchange of knowledge for time, and if done safely, we can buy back time in order to prevent burnout, make good decisions for our patients, which in time is the most precious resource in the world, right? What scares me the most is the ability of scale, right? And I think that's sort of the flip side of the promise of AI, right? AI is useful because it can scale and can influence hundreds of thousands, if not millions of patients, but also that means that any mistakes, any biases that are inherent in it also scale and can reach millions of patients. And that's where it's a problem, right? Because if you make a mistake, you as a physician, you affect one patient, and that's regrettable. But if you make it a systematic, repeatable mistake happening, then that can affect many, many more patients than you thought before you catch it. And that's why continuous monitoring is key.
There's a couple of worries that I have, and one is that our AI systems may exacerbate inequities. I know that's apparently a dirty word now. It shouldn't be, but the potential for it to make our health setting, our health system, more inequitable than it already is concerning. I mean, I see this all the time in Silicon Valley. In one day I can see in my clinic a billionaire. They have the access to everything. They have knowledge, health literacy. They can get specialized one-off cancer vaccine that's just made for them, you know. And I worry that AI is going to exacerbate that. Whereas, on the same day, I could see somebody who, doesn't have a house, is living in a shelter, and they have no access to anything, and they don't even have a phone. So we are like, hey, well, use your phone, contact me on my health. Right? What if you don't have a phone, right? What if you don't know how to use it, right? So all of these capabilities are not accessible to you. So that's one concern. The other concern, you know is really the energy requirements, right? I mean, if you look at it, it's just crazy how much energy this requires. I mean, you just look at, I mean, you have personal evidence in your hand. If you've got a newer phone, the phones get hot. And the phones get hot even with these great, processors that Apple has, because, AI uses up a lot more power than non-AI systems. So that's concerning if everything has AI as kind of part of it, and we're building all these data centers, right? At what point are we, causing a problem because the energy sources are not renewable or not even available? And again, that can also exacerbate inequity, right? Where are they putting the data centers, right? Not near me. They're not putting it in Palo Alto, I can tell you. And again, my great hope is kind of what I mentioned before. I think we have this great ability now with our technology and data to cure disease, or turn serious illness into a chronic illness, because the data, and it is not going to be fast, but how research is very time and person intensive. So those are the things that AI is good at, right? Doing things repeatedly, doing them, looking at a large amount of data. So, I have the greatest hope that we are going to have so many new treatments for the future. And then, we'll be talking about cancer like it's diabetes. That's my hope.
Okay, so now that has been very, very insightful, a few rounds of Q&A with us, but we don't want to monopolize exchange. So we do encourage everyone to type your questions using the Q&A button at bottom of your Zoom. And now, so Dr. Wolf and I will take turns to choose a few questions and for Dr. Lin and Dr. Nadkarni to answer. First question I see here is the one from Dr. Shin. If you are comfortable sharing, what are the top 3 ways you personally use AI for either in healthcare setting or outside the healthcare setting today that has helped make your life easier? And in what areas do you wish AI could do more or go further to have your life easier? So, Bryant, go ahead, either way.
No, Brian, go on.
Oh, I'd say number one, doing the so-called deep research. It's very time consuming to do literature reviews. And so it's not a replacement, but it's a great way to start. So that's saved me tons of time because, as academics, we're always curious about a million different things, and you don't have time in the day to research a million different things on literature. So that's probably the number one way. I would say, number two is, we were actually talking about this earlier, kind of automating or making complicated tasks shorter. So writing letters, things like that, where we need to synthesize large amount of data and put it into a letter or some other sort of document. We're starting this tool at Stanford where you can basically it's called chat EHR, where you can basically chat with the EHR. So it'll help you look up stuff in the EHR fast. So I have high hopes for that. I think the third thing is more of a personal thing. Recently, I had my sabbatical, went to Japan, and I had it planned the itinerary because we were gone for a month. So, it's complicated to think about where do you go next? Where do you go next? Right. And, I didn't adhere to it strictly, but it was very helpful to say, okay, you can take this loop and go. And, I thought it was great to do that.
Yeah, so sort of in my clinical role, AI has made it easier in terms of ambient AI because now I can spend the entire 20 or 30-minute visit talking to the patient as opposed to like typing 15 minutes of it into a computer. That's one. In my research role, sort of one of second Bryant's thing, deep research has made it easier. I mean, obviously you have to check references and make sure it's kosher, but it compresses hours of work into 30 minutes or less. And then in my personal role, I actually I have a 5-year-old daughter, so I turn ChatGPT voice and ask it to tell a story so actually I can get to some work. So that's me. I mean, I actually set guardrails around it. I can share the prompt for that, but my daughter always keeps asking me to tell her stories. So this is an automated way to tell her stories.
That's a great uses.
A side comment, people always ask me because, we live in these crazy competitive area with parents. Like, what do you tell your kids? I know people out there are like, oh, what do you tell your kids to do with AI? Sound like my kids a little bit older. Um, but yeah, I just, get used to using, not in a bad way or cheating or anything. I encourage my kids and to just use the systems, right? I mean, you got to be familiar. The term AI native is not a joke. I mean, that's what we kind of, I hate to say, we've all got to become AI natives at some point, but hopefully not using the systems without guardrails, but also, inappropriately to cheat or to not do your homework. So like my younger son, he's uh, 13 and he uses it to code like little games and create a chess engine. And, it's a lot of fun. And, he's learning he knows more about some of the latest LLMs than I do because he's like right on it. He told me, Daddy, they just released ChatGPT 5. And I was like, I had no idea it was being released today. So, kids can be, well, kids are always ahead of the curve technologically, honestly.
That's great. So a question from one of our attendees. So how do we know and ensure that we're not just using AI in healthcare for the sake of technology and actually solving problems? And they said they see some solutions that just create another set of problems and creating more work. So how would you respond to that?
I completely agree with that, right? I mean, if you use technology for the set of technology, you haven't solved any problems, and you have created a whole new list of problems, and that's why you have to start off with the why. Why are you doing this, and what problem are you solving, and then work up from there, as opposed to taking a hammer and start beating on random things because it's a hammer. You've got to find the nail first, right? So yeah, I completely agree. That's why I think it has to be, and we didn't get time to talk about this, but at every governance, when things get implemented, you have to ask, what is the problem you're solving? What is the workflow that you're mapped out? Where is AI helping with the workflow? What happens if it goes wrong?
I think a great example is like when EHRs, EMRs, electronic health records, electronic medical records were implemented at first, right? We did not necessarily see direct, clear benefit at the beginning. And it took a long time to see some benefits. And there are still some people who argue, the new problems it created, there's a perception that, oh, it's interfering and, ambient AI is addressing that with, the patient-doctor relationship. So absolutely, that's a concern. I also give an example. So we piloted and we have now, in implementation across many clinics, an automatic, not semi-automatic reply for my health messages. So a lot of physicians complain about, oh, we live in our inbox all the time. We get all this flood of patient messages and results and, charts, sent by colleagues. And when that pilot came out, I was so excited. I'm like, oh, great, this is going to help me. It's going to draft a response for me. So, I used it for about a day and then I stopped using it. So, that's usually what happens when you have a technology that, people don't find useful for them, they'll stop using it because it's usually not, hopefully not implemented in a way where you have to use it. And the reason was, it wasn't writing in my voice. It was writing a really long message. It took longer to edit the note than it would have taken me to write a shorter note. So, it's just like, kind of not, didn't feel comfortable or it didn't feel like it was saving time. However, on the other side, the answer, I think the other part of the viewer's question, we hopefully are testing these things and looking, is it a net benefit? So my colleagues did a study on that pilot and did find, the perception of load maybe didn't change, but the burnout sensation did decrease for the people who used it. But the utilization wasn't, 100%, right? It was, I can't remember exactly what the number was, but I think that's important to make sure you're not forcing people to use things that they may not see benefit from.
So the next question we have here from Dr. Harold Lachman, the Hopkins here. So he was asking this question of using quantitative decision sciences to help with medical decisions. So the question is that when we think about AI or even possibility of ASI, are we going to be able to use more of experiences from that profession, from decision sciences, decision modeling, to help us make medical decisions?
Absolutely. I think that is critical about teaching quantitative as well as qualitative decision sciences in medical school. And that's, I think Bryant mentioned it earlier. We haven't changed medical education in a while, but I think now we need to change it, incorporate decision sciences, AI literacy, human-centered design, empathy, all into medical education, because the role of the doctor is going to evolve, and all of these things are necessary for decision sciences, right? And I think decision sciences are especially critical because in medicine, everything starts with a decision to do something or not do something, right? And balancing the risks and benefits.
I'm never envious of my colleagues who design the curriculum and run the school, because it's so challenging. There are so many requirements, and I mean, basically you can't fit them all in. I mean, I'm just amazed at these 3-year medical school pathways, because you really can't fit in a lot of things, and anytime you add something, you've kind of got to. So it's challenging. I mean, yeah, it's definitely. I do think a lot of this decision analysis is implemented in education in different ways, and it's more distributed throughout, as opposed to, necessarily a discrete kind of, this is your session, or these are your, 1 week course on decision analysis. But yeah, it's absolutely important but challenging to implement new things in the medical school curriculum.
Well, thank you for answering those questions. I know there's probably a few more, but we are getting close to 1 o'clock, and we want to be respectful of everybody's times. We are so grateful to our panelists today for sharing their insights on AI and ASI, and we hope that there'll be opportunities for discussion, collaboration in the future. This is really, really informative.
Great. Thanks so much.
Thank you.
Thank you, everyone, for joining. And let's keep the conversation going. And we'll be, for those who are part of work group, and we'll be making announcement about the next event pretty soon. So stay tuned. Thank you, everyone.